central photo represents the primary position, right? But if the patient has an abnormal head posture, the first step is to correct the abnormal head posture. Make sure the head is straight ahead. And at this position, we call it forced primary position. In order to detect the abnormality, you have to know the normal. So try to test the versions on any of your family members, like your children or whatever. So try to test the normal range of ocular rotation. Sometimes we call it ocular rotation, but this is the more specific, but generally we use versions. So this is from a Korean paper, and as you can see, the facial features of Korean people. You have to know the normal, what is the normal adduction, what is the normal abduction, and so forth. What do you think is the maximum movement? I mean, we have abduction, adduction, elevation, and depression. What is the maximum movement in degrees? What do you think? Do you think the adduction is better than, or the amplitude for adduction is better than the abduction? And how about elevation and depression? Do you know the order? So actually, in degrees, according to this paper, and if you test, you will notice this. The depression is about like 46 degrees. So the maximum movement the eye does is the depression. The movement, the range of movements is maximum for depression. And if you think for a while, we need depression a lot during walking downstairs, during reading. The depression is very precious position of gaze. So in squint, when we have a squint cases, we care about the ocular alignment in the primary position. And the second important gaze is the down gaze. These both gazes are the most important gazes, the primary position and the down gaze. So the maximum movement in depression, followed by looking out abduction, and then adduction, and the luxurious, sometimes they call it luxurious, like it's, we don't need a lot elevation, especially when we grow older, like children need elevation because they are shorter than most people. So elevation is very important for children. But as we get older, we usually tend to chin elevation to look up. So elevation is the least movement, and it's decreased, markedly decreases with age. All right. This is a kind of academic piece of knowledge, but while testing the version, the horizontal version, you should notice that the normal adduction, in normal adduction, the nasal limbus is not seen. So I hope you appreciate in this slide that the adducting eye, you can't see the nasal limbus. I know this is a Korean subject, but even in non-Koreans, normally the adduction, you can't see the nasal limbus. So if you see the nasal limbus during adduction, it means that there is a limitation in the adduction. Somehow decrease in the range of adduction. So once more, normal adduction, you can't see the nasal limbus. How about abduction? So in abduction, you can see the temporal limbus, but it should not be any visible scleral triangle. So here's a difference between adduction, normal adduction, and normal abduction. In normal adduction, you cannot see the nasal limbus, but in normal abduction, you can see the temporal limbus, but it should not be visible in any visible scleral triangle. Got it? So let's comment on the adduction in this girl, in the right eye, in the right side photo. So in the right side photo, this child is looking to the left, so this is a levo version. So the right eye is abducting. So as you can see here, you cannot see the nasal limbus. So this is a normal adduction. Actually, there is some overaction, but regarding our piece of knowledge right now, this is considered as normal adduction. And in the left side photo, this is normal abduction. It's hard to comment on this photo, but actually, in this case, you can see the temporal limbus, and there is no visible sclera behind the temporal limbus, so this is normal abduction. So the horizontal movement in the right eye is normal, whether adduction or abduction. And in the middle photo, once you see my hands or the examiner's hands above and below, like over the chin and over the forehead, it means that this child most probably has got an abnormal head posture, and the examiner is trying to align the head to check the alignment at the primary position, and this is called forced primary position. An abnormal head posture, sometimes you may be confronted with the case, and the most obvious sign is abnormal head posture. So try to spend a few minutes analyzing what could be the cause of this abnormal head posture. So sometimes we call it abnormal or anomalous head posture. In some references, they write EHP for anomalous or abnormal head posture. In other references, you may find this abbreviation, CHP, compensatory head posture. Anyhow, sometimes the abnormal head posture is just one component, like face turn. And you should say face turn to which side, like right face turn or left face turn. And it could be only chin elevation or chin depression. So you have to be specific when describing the abnormal head posture. Of course, for chin up and chin down, we have two options, chin up or chin down. But, and again, in face turn, it could be right face turn or left face turn. And we have also another component, which is the head tilt. So we can have right head tilt or left head tilt. In some cases, if the problem lies in the horizontal movement, we will get face turn, like in Duane syndrome. So Duane syndrome is like abnormalities in either the adduction or abduction. So we will get face turn, just face turn. No chin up or no chin down, no head tilt. But if we have another important examples, exam-wise and in clinical practice, is forced nerve palsy. Because forced nerve palsy, the superior oblique muscles have three actions: depression, abduction, and intorsion. So the abnormal head posture is complex. We have a component of face turn, we have a component of head tilt, and we have another component for chin. So you have to know the components for each abnormality. Once there is an abnormal head posture, this signifies two things. So this is a question for you. What is the significance if you see a case with abnormal head posture? This means that the case, this is have a prediction, like you predict the two things.
The child is probably having binocular single vision.
Yes.
The child, yeah.
So
and to avoid diplopia, in case of an adult, to avoid diplopia.
Excellent, excellent, Dr. Hasika. So the child adopts this abnormal head posture, or if we have an adult and after trauma got an acquired strabismus, so the adult can adopt abnormal head posture. It's not always children, but also in acquired strabismus. So sometimes the patient will adopt abnormal head posture to avoid diplopia. And so you know that there is a kind of binocular single vision. In Kanisky, in the new edition of Kanisky, he said to avoid amblyopia. And I found this word a little bit confusing because for children, for congenital strabismus or early onset strabismus, the child will adopt this abnormal head posture to maintain the binocularity. But without hip posture, there will be strabismus in the affected eye, and over time, there might be strabismic amblyopia. So the word is correct but confusing. So, so as Dr. Hasika said, to avoid diplopia and maintain binocular vision, and also this is protective against development of strabismic amblyopia. So you got the idea, because I think this amblyopia is confusing and the examiner may don't like this word at first. You can say it at the end of your answer. Okay. Another significance of abnormal hip posture, once you see an abnormal hip posture, it means that if you correct this hip posture, you will find strabismus in the primary position. Most probably you will find strabismus in the primary position, and that's why the child or the patient adopts this abnormal hip posture in the first place. So the significance of observing an abnormal hip posture, it means the patient is maintaining binocularity to avoid diplopia, and if it's child, to avoid strabismic amblyopia. The second, it means that if you correct the head, you will notice strabismus in the primary position. There is another significance. You have to correlate between the abnormal hip posture and the version movement. There must be a limitation in one gaze or more. So if the cause of abnormal hip posture is strabismus, because in this slide, as you see, the bottom title, there are different causes for abnormal hip posture other than strabismus. But the strabismus is the most common and the most important cause of abnormal hip posture. So if you have a case of abnormal hip posture, you have to be careful while examining the motility, versions, adductions, and so forth. But if everything is looks nice and normal, you search for another causes of abnormal hip posture. Because Dr. Hasika is going to the exam, so do you know another cause for abnormal hip posture other than strabismus and other than nystagmus? Because nystagmus. Go ahead.
Bilateral ptosis or severe unilateral ptosis.
Okay, so you will get chin up position, right?
Yes, ma'am.
So once you mention the cause, mention the finding. So you said severe ptosis. So
chin up.
So chin up. And this is actually protective against the deprivation amblyopia. Here, what I mean by the observe, because in assessment of a case of strabismus, the first step is to observe. One of the important signs is abnormal hip posture, and it gives you a clue for the expected finding. And the next step here, I mean, when you try to check the alignment, you should correct the head posture. So in this slide, this is because some learners get confused about some schematic or diagrams in strabismus. If you find the two eyes at the top of the page, as you can see, so I'm using now the laser pointer. I'm pointing now on the left side of the slide. In this, in the left side of this slide, when you see the two eyeballs are drawn like this, what do you think? Which eye is the right eye and which eye is the left eye?
Is the left eye.
This is the left eye, okay? And
yes.
In the left side
is the right eye.
Excellent. So diagrams like this, it means that you are looking at the patient. So this is the right eye, and this is the left eye. So sometimes we use this kind of diagrams. So the two eyeballs at the top. So you are facing the examiner. You are facing, sorry, the patient. You are facing the patient. It's like a mirror image. But so this is the right eye, and this is the left eye. Okay. But how about this diagram at the bottom on the right side of this slide? It's the opposite. It is like it is like as you are looking at the laptop, it looks like you are the patient. So what is the right eye? This is the right eye, and this is the left eye. In some references, they may use the lower diagram, this one, and other reference use the other. So you have to, in order to understand the schematic representation during studying, because some learners got confused between which eye is right and which eye isn't. And you have to be familiar with these abbreviations. Although in the exam, try to avoid abbreviation. So if you have a case of exotropia, don't say XT, especially if the exam in Cairo, because Egyptians don't like abbreviations. In general, maybe the new generations do use the abbreviations a lot, but try to say it, because we are not fast speakers like Indians, and we even in my own language, my mother tongue, we don't speak so fast. And also, we are not Americans. Americans love abbreviation. Say it exotropia, don't say XT. And likewise, ET, it means esotropia. So XT means manifest divergent squint, and ET means manifest convergent squint. But because I'm gonna say it during the presentation, so XT means exotropia and ET means esotropia. All right. And also you have to be familiar with the dextroversion, levoversions, and so forth. Because adduction and abduction may be confusing in pronunciation, so I will say it adduction as a one word, but in abduction, I will say it abduction to make somehow discrepancy in the pronunciation. Okay, we finish now the warm-up, and this started by Duane Retraction Syndrome. You can say Duane, or you add the apostrophe S, Duane's syndrome, but try to remember the full name, Duane's Retraction Syndrome, because retraction here is a keyword. This is actually the hallmark, the main feature of Duane syndrome. So we again, I watched a wonderful lecture, the first part of a wonderful lecture by Cyberside about Duane Retraction Syndrome. The speakers are two speakers are Indians, very famous, and they use DRS all the time. So I never use DRS, but so that's why I'm saying you get used to say abbreviation, but here we don't say abbreviation, we say Duane syndrome. But it's interesting because it saves time if I say DRS. So there are some points you have to know about Duane syndrome. First, it should be congenital. There is nothing called acquired Duane syndrome, right? So, but sometimes in the exam, you may have an adult, but the onset of strabismus is dating since childhood. And that's why in clinical practice, we sometimes ask patient to bring all the photos if the patient is an adult age group. So this should be congenital. This is in contrast to Brown syndrome. Brown syndrome could be congenital or acquired. So as you see now, I'm trying to correlate the information because you already have the foundation, you already have the knowledge. I'm trying to like stressing on some points, make a kind of revision in different way. So we always study Duane syndrome and Brown syndrome afterwards. So try to make correlation. Correlations deepen your knowledge and make it memorable. So Duane syndrome is congenital, almost always congenital. But Brown syndrome could be congenital or acquired. And this is important because sometimes in the exam, they will ask you about the etiology. So if you have a case of Brown syndrome, don't forget the acquired causes, but because this is a common mistake. But Duane syndrome is by nature, is congenital syndrome. And it is non-progressive, and this is good. and not uncommon. So not uncommon, so I learned this expression from Kansky. Not uncommon, it means some way between common and uncommon. So it's easy to get at exam, especially if you your exam in Cairo. I don't know the situation in India, but in Cairo we have a lot of cases of Duane syndrome. It's very easy to get a cases of Duane syndrome, especially type 1, because type 1 is the most common type of Duane syndrome. So there is something called hallmark, or the main feature, or the telltale sign, or the pathognomonic sign. So the main feature of Duane syndrome. So Dr. Hasika, can you read the first line?
Lid fissure narrowing in adduction, widening in abduction.
Excellent. So as you see here, the main features, it's about the lid fissure, the palpebral fissure. And this points that to the importance of noticing the change in the width of palpebral fissure while testing the versions. So while you are testing the versions, you are commenting on the on any limitation on the actions in each eye, but also notice the changes in the vertical width of the palpebral fissures. Because narrowing in the fissure in one eye in adduction, but widening on abduction, it means 99% is the case of Duane syndrome. In some textbook, because the most common type is type 1, and in type 1 we have limited abduction or absent abduction. Sometimes they add the word widening in attempt abduction, because the patient is unable to abduct his eyes. So in some references, you will see the sentence like this: palpebral fissure narrowing in adduction and widening on attempt abduction. Okay. Despite the fact this is the hallmark, but we need the second sentences here. It should be there should be limitation. There should be limitation during horizontal versions. So despite the fact that the first sentence is the hallmark, but still we need the second sentence. There must be limitation in the horizontal versions. But why we put this limitation in a smaller font in the lower position? Because limitation in horizontal versions have a list of differential diagnoses. There are many causes that can affect the horizontal versions. We have many causes that may cause absent abduction, like sixth nerve palsy. So the second sentence is non-specific because this is a differential diagnosis. But once you see limitation in the version and this hallmark, the first sentence, you are sure now this is a case of Duane syndrome. Got it? So in this slide, the pointer now is aiming at the middle photo. So I'm taking some history because this is one of my cases. I have taken this photo after dilatation. So the pupils are dilated, as you can see. And Hirschberg test looks like central in each eye. So this seems to be orthotropic. So remember yesterday, since we are commenting based on the Hirschberg, you have to say it seems to be orthotropic because Hirschberg test is not specific or not accurate 100%. So there is narrowing of the fissures in both eyes because the patient actually doesn't tolerate the flash of the camera. So this is pseudo, like she is a little bit squinting or squeezing her eyes because of photophobia. Now, looking to the right side, we call it dextroversion. So the right eye doesn't move beyond the midline. So we have a limitation here in abduction. All right. And on looking to the left, levoversion, in the upper photo, we have upshoot. And in the lower photo, we see downshoot. And we see also extreme severe narrowing of palpebral fissure. So I want you now to see whether the hallmark is here or not. So it's here because we have narrowing in adduction in the right eye and widening in abduction. So the hallmark is present in the right eye. And also we have limitation, which is limited abduction in the right eye. So this is a Duane syndrome for sure. Okay. And some cases are bilateral. This is we can say this is not the most common presentation. The most common is unilateral. So be careful of saying bilateral Duane. In Kanisky, the new Kanisky, he said the majority of cases are bilateral. I checked the Google references. I don't know the reference, but in most textbooks, in most references, the majority of Duane is unilateral. So so the left eye here is normal actually. So the abducting is abducting nicely, and it is abducting nicely, and there is no change in the fissure between abduction and adduction, no significant change. So the left eye is okay. But the problem lies in the right eye. So if we now try to give a full diagnosis, this is a case of Duane's retraction syndrome.
Ma'am, I have a doubt.
Say it.
In abduction, the widening of palpebral fissure is not seen always, ma'am. It is the narrowing which is the hallmark. Because in this case, I don't think there is widening of palpebral fissure on attempted abduction. What do you say, ma'am?
So the widening is in comparison to the narrowing. So you compare the palpebral fissure in adduction, you see, in this photo.
Yes,
and you compare it by the abduction on attempt abduction. Definitely there is a change. Ignore the primary position, especially in this case because she is squeezing her eyes because of the flashlight. So we have narrowing here, all right, and widening relatively or comparatively to this narrowing.
Okay, ma'am.
And actually, in severe cases, you will notice the retraction, and that's why it is called Duane Retraction Syndrome, because you know the pathology in Duane syndrome, there is on adduction, there is contraction of the medial rectus because medial rectus should adduct the eye, but at the same time the lateral rectus is contracting, so we have misinnervation here. So contraction of the medial and lateral in one eye. So we have the muscle and its antagonist muscle is both are working together. So they push the retract the globe inside the orbit, because as you know, the rectus muscles, its origin from the apex of the orbit and its insertion anteriorly anterior to the equator near the limbus. So when the muscle contracts, the insertion comes closer to the origin. So imagine now, I will show it in a moment. So contracting of medial rectus and lateral rectus both will retract the globe backwards in the orbit. So due to this retraction, the eyelid fissures becomes smaller. So the upper eyelid descends a little bit and the lower eyelid elevates a little bit. All right. Because the width of palpebral fissures depends on the globe. So if you remember, if we have a case of atrophia bulbi, atrophia, you will see narrowing of the fissures because the globe becomes smaller. So here the globe is retracting in the orbit, so the fissures becomes small. All right. So in the bottom photo, there is downshot. Sometimes the cornea is hidden below the lower eyelid, and in severe cases of downshot or upshots, the cornea might hidden under the eyelid. So here on levo versions, there is downshot, and this is another additional features of Duane. In this photo, actually, this is not exactly levo version. It's like up and to the left. It's like levo elevation. So in comparison, this eye elevates nicely, but this eye, there is a kind of super elevation. So we call it upshoot. Got it?
Ma'am, I have doubt, ma'am.
Yes, say it.
In the lower picture, there is downshoot, and in the upper picture, there is upshoot. Can we say in the lower picture, there is superior oblique overaction, and in upshoot, there is inferior oblique overaction, ma'am?
This is a specific diagnosis, and already from your study, you know that in Duane syndrome, we have something called upshoot and downshoot, and the cause is not oblique overaction. The most accepted theory is mechanical. I will say it in a moment.
Okay, ma'am.
So seeing overaction, superior oblique overaction or inferior oblique overaction, it is a specific diagnosis. But the broad term is upshoot or downshoot, especially when you know that this is a case of Duane syndrome. Because if you say this is a superior oblique overaction, the next question, why there is superior oblique overaction in a case of Duane? You get in trouble, right? So this is called upshoot or downshoot. And Kanisky has a book called The Differential Diagnosis. I don't know if you know this book. It's a wonderful book. It's an old book, Differential Diagnosis. He said, what are there is a list for causes of upshoot and downshoot on adduction. This is a kind of compilation list. I will go through it at the end of this part, but after in the third or the last lecture. What are the causes or upshoot or downshoot? So Duane is one of them. Okay. So don't say here superior oblique overaction or inferior oblique overaction. Say upshoot or downshoot. Especially you already know this is a Duane, and we will see that now in that the mechanical theory is mainly the cause for upshoot and downshoot and not oblique overaction.
Yes, ma'am, understood, ma'am.
And as you can see here in this bottom photo, mom is fixing the head because the child try to move his head because this gaze is the troublesome gaze. Looking to the left is very troublesome. So I have an important point here because the troublesome gaze for this child is actually should be to the right? Correct? Because the dextroversion is the problematic gaze because this eye is not abducting. So the child have a problem looking to the right. But also this child has a problem looking to the left because of this downshoot or upshoot. So this child has two problematic gazes. The right gaze, because the right eye can't abduct, and the left gaze, because this vertical misalignment, because upshoot or downshoot, it's kind of vertical squint, it's kind of vertical misalignment. So Duane syndrome is a problem in the horizontal versions. So we have abnormalities in the horizontal direction. But if we have a super added upshoot or downshoot, this adds another problem because we will get another vertical squint on adduction. All right. What is the pathology of Duane Retraction Syndrome? Or the etiology. So is it restrictive or paralytic or other?
Ma'am, it is a other, ma'am. Can I explain?
Yeah, go ahead.
In Duane's retraction syndrome, there is a agenesis of sixth nerve nucleus or sixth nerve, as a result of which the nerve to medial rectus, which is the inferior part of the inferior division of the ocular motor nerve, it divides into two and it supplies the medial rectus as well as the lateral rectus. That is, yeah, but it can't be paralytic or restrictive, so it is something else.
Perfect. Okay, so do you know they give another term, like there is a term, it's written in Kanetsky, New Kanetsky. So Duane Retraction Syndrome is under a big heading called CCDD or CID. So do you know this abbreviation, Dr. Hasika?
Congenital cranial disinnervation disorder.
Okay, so congenital cranial disinnervation disorders, or sometimes they say CID, congenital innervation dysgenesis. So as you can see here in either in this term or this term, congenital is the first one, and this stresses on the importance of knowing that Duane is congenital. And cranial, so as Dr. Haska said, because the problem lies in the agenesis of the sixth nerve nucleus. And so this is one insult here, or one pathology here. The second pathology, the third nerve, the oculomotor nerve, which supplies the medial rectus, split to supply the lateral rectus. So we have disinnervation. So that's why there is disinnervation. And this is a disorder. And if we have a case of Duane Retraction Syndrome, you should decide whether it is isolated or associated. So some cases, the majority of cases are isolated. So the only abnormality is the Duane Retraction Syndrome. But sometimes the patient has another problem and we call it associated. There is a list for the associated disorders. So I mentioned only the most important or the common ones. So deafness is the most important. So don't forget deafness. Because during the discussions, I guess during the clinical exam, if there is a time, they may ask you about the association of Duane Retraction Syndrome. So you have to check for deafness. And I remember one of the old assignments in problem solving, so it was about a case of golden hair syndrome with Duane Retraction Syndrome. So golden hair syndrome is one of the syndromes that might associate with Duane Retraction Syndrome. So we have combo syndromes here. And also Marcus-Gunn-Joe-Winking ptosis, and you all know this abnormality. And actually in New Kanetsky, they consider now Marcus-Gunn as one of the CCDD also. So you have, whenever you have a case of Duane Retraction Syndrome, you can tell the examiner, for example, you have to search for associated disorders. Consult the pediatrician, for example. Check for deafness. Just a quick summary for golden hair syndrome. This is a very commonly asked syndrome in exams. So in this photo, we have limbal dermoid and we have hemifacial asymmetry, acrotia, coloboma of the upper eyelid, skin tags, and you have to add in your textbook or your reference Duane Retraction Syndrome. So the features, the ocular features and the systemic features of golden hair syndrome is important, and kindly add Duane Retraction Syndrome. All right. Moving now to the types of Duane Retraction syndromes. So this is a question. How many types of Duane Retraction syndrome? 3, 4, doesn't matter.
3, ma'am.
Dr. Hasika said 3. And in Kanetsky, it's 3. And for general ophthalmologists, for candidates for the exam, they are 3. But if you are dealing with strabismus cases, they added another type. So we have 4 types. So if you see 3 is correct, if you see 4 is correct, and if you see doesn't matter, it's actually some strabismologists doesn't document the type of Duane retraction in the file. They only mention the signs, the findings. They don't say type 1, type 2, type 3. They say isotropic Duane, exotropic Duane, orthotropic Duane, and that's it. They only document the findings. But back to the basics, as written in Kanisky, we have 3 types, as Dr. Hasika said. And try, whenever you have types, try to make it in the table and try to correlate the features opposite to each other. So we have type 1, and as you can see, I made encircling type 1, like a border for type 1, because this is the most common, and most commonly you will get type 1 in exam. Type 2 is relatively rare. Type 3 is the second common. So as you can see here, the incidence in type 1 is most common, followed by type 3 and then type 2. Let's go one by one. So type 1, and in some textbook, even when they mention the features of Duane syndrome, they only mention the features of type 1, because this is the most common presentation. And as you remember, the previous case actually was type 1. So type 1, we comment on abduction and adduction. Okay. So we have absent or limited abduction. So abduction is the affected movement, but adduction is normal. And I found the word mild limitation confusing. So you will see in a moment that I will omit this mild limitation. So simply, you can say in type 1, the adduction is normal and the abduction is affected or limited. So try to simplify the information, because we have a lot of information you have to know. So try to simplify. It's not bad to try to simplify. So type 1, adduction is normal, abduction is affected. And how about the primary alignment or the primary position? It could be orthotropic or slightly isotropic. Again, omit slightly, because slightly depends on the measurements. So you can say ortho or ET. Okay. In Kanisky, he said straight eyes. So straight eye, in strabismus, we don't usually say straight eyes. We say orthotropic. Okay. So this is type 1. And I added the fistern, because fistern, maybe the first sign you picked is the fistern or the abnormal hip posture. So since the abnormality in the abduction, so the fistern would be ipsilateral. If you remember previous presentation yesterday, we mentioned that if the abduction or the lateral rectus is not acting well, the fistern will be on the same side, because the lateral rectus or the abduction is a movement that occurs on the same side. So back again to this case. Here is a laser pointer on the right eye. So the right eye doesn't move to the right, because the lateral rectus is acting on the same side. So the lateral rectus is not working. So the child can't abduct to the right, and the problem is the right. So we expect fistern to the right. So we have ipsilateral fistern in type 1. So if we have a Duane syndrome in the right eye, type 1, the fistern, if there is a fistern, it should be right fistern. If we have a Duane on the left eye, type 1, and there is a fistern, it should be left fistern. So in general, it's ipsilateral fistula because the limitation is in the abduction. Got it? Here in the middle photo, this is the primary position. This is the forced primary position because, as you see, the mom is fixing her child's head. Here there is slight esotropia in the right arm. Okay. On adduction, there is narrowing, slight narrowing, because this is an infant. So the narrowing may be so slight or subtle in young cases. So relatively, there is narrowing. But how about abduction? Looking to the right, there is limitation in the abduction. So we have limitation in abduction, normal adduction with narrowing. So this is a Duane type 1 in the right arm. Type 1, we will get ipsilateral fistula. And since this is the right eye Duane, so as you can see in this top photo, we have right fistula. So as I said yesterday, you have to spend a few seconds on each photo, like try to analyze the signs, correlate the signs together. So the fistula matches the version testing, the abnormalities or the signs. So here again, this is labeled the slide. So this is the fourth primary position, the right eye. We used to say OD. So in Strabismus, we usually use this Latin abbreviation OD for right eye and OS for the left eye and OU for bilateral. So OD, we have a small angle esotropy. We use the expression or the word small angle, large angle, because someone said before a slight angle. So or Kanitsky mentioned slightly angle. So we use the term small angle. And here in on dextro version there is limited abduction, and on adduction or levo version we have narrowing and normal adduction. So this is type 1. Type 2, you can simply know that type 2 is the opposite of type 1. Okay, so know type 1 by heart, make the opposite for type 2. So here the abduction is the affected movement. Here the abduction is normal. Ignore this part. So normal. Here in type 1, the adduction is normal, but here is the affected, it's absent or limited. So type 2 is the opposite of type 1, and it could be ortho or XT. All right. So on adduction, you will get narrowing and limitation of the movement. And on abduction, normal. The primary position, if you fix the abnormal hip posture, you will find ortho. Actually, no, if it is ortho, there should not be abnormal hip posture. But if there is a fist turn, once you fix the fist turn, you will notice exotropia.
Ma'am, there is in type 2, there is adduction limitation, right? But still there is a narrowing, ma'am, in type 2.
Yes, because this is the hallmark.
Okay, ma'am. Okay.
But I didn't write narrowing in this tape because we already mentioned this is the features, the common features in all types. And that's why I said, I will repeat it again. In type 2, you will notice two findings: narrowing, because this is a feature of the Duane, and limitation of the movement. And don't forget the upshoot and downshoot in any of these types, it could be present. And the upshoot and downshoot in Duane's, it happens on adduction, So you may get 3 signs on adductions. you may get you will get narrowing, which is the main feature. You may get upshoot or downshoot, and the last one depends on the type. So type 2, we will get limitation. For example, type 1, it should be normal, generally normal. Type 3, again, it's limited. So the adduction is very important in Duane, because you may get many signs. How about the first turn in type 2? So the limitation in adduction.
So the face turn will be towards the opposite side now.
So in strabismus, we use another word for opposite side.
Contralateral side.
Yes, contralateral sides.
Yes.
But your answer is correct. But as you know me, maybe you know me, that I'm trying to as much I can to make it professional. And so the examiner, when the examiner sees that you are using more specific terms, more professional terms, you will know that you are very good candidate. So even if you do mistakes in other parts in the questions, or you missed some informations, you will forgive you. So because the examiner, although the examination is objective and he have like model answers and marks for each question, but again, he is or she is a human, and I think there is some element in the exam, like psychological elements or non-objective element. There should be some non-objective elements. So if we say contralateral, ipsilateral, these terms means that you know good what strabismus is all about. Like you attended a strabismic clinic, you are seeing strabismus cases. So here, this is a contralateral first turn because we have limitation on in the adduction. Adductions, we need the adduction when we're looking to the contralateral side. So remember yesterday, if we have a problem in the adduction or the medial rectus action in general, or adduction, I mean in general, because we use the adduction when we are looking to the contralateral side. So we need the adduction. For example, the medial rectus on the right side is acting on looking to the target to the left side. So we have contralateral first turn. So suppose I'm asking you, what is the first turn in Duane syndrome? So the best answer is to say it depends on the type, because in type 1 you will get ipsilateral first turn. In type 2 we will get contralateral first turn. In type 3 it's variable. It depends on the alignment in the primary position. Okay. So remember this slide. So this girl. So if you remember this girl, I made this artistic change because we are trying to camouflage the personal identity. Nobody wants to be known as a patient, and we add this star in the background to make some distraction to you. So I'm trying to distract you, and this emoji, all these are distracting factors because I'm trying to simulate the condition during the exam, because you will get a lot of distraction from the surroundings, might be, or you are stressed out, so your focus is not 100%. So the first turn here, mainly it's first turn, and you said before, this is a right first turn or left first turn? Because the side is very important. So is it a right first turn or left first turn?
Left face turn, ma'am.
Left face turn. And we agreed that the patient turns his head or her head towards the affected gaze. Like, so what do you say? What do you expect is the problem here? Since she is adopting left face turn, left face turn, so the problem in the left gaze. So the problem in the levoversion. And you answered this slide previously correctly. So let's say this case, in the primary position, or let's say in the fourth primary position, after correction of the hip posture, you will see exotropia. And you have to mention the side. So we have exotropia, despite there is no Hirschberg, because this is a little bit hazy, all the photo, because as I said, type 2 is relatively rare. And maybe I saw this photo, this case like maybe 10 years ago. So this is bad quality because it's old photo. And there is no Hirschberg, but you can appreciate at least that the nasal scleral triangle is bigger in the right eye. This is an exotropia in the right eye. All right. So in the primary position, there is exotropia. And looking to the right, I'm saying this, the abduction is okay, is normal. The abduction is normal. But looking to the left, there is upshoot, and actually there is, we consider is as a limitation because the eye doesn't move medially. So we can say it is a limitation on adduction and upshoot. So we consider this case according to the files as type 2. So this is type 2 exotropic Duane on the right eye with upshoot. According to the photos. So according to the photos. And sometimes you need to justify your answer to the examiner. Try to be elaborate. And if the examiner feels that you are saying too much, he will cut you. He will cut you off and he will stop you. Okay, but try to show your knowledge if you already have this knowledge. So if I'm now in the examinations, I will justify my answer. So I will say, if I'm confident with my diagnosis, I will say there is exotropia in the primary position. Let's see here from here. There is a left fistula, and there is exotropia in the primary position, in the fourth primary positions. On what's it? Dextroversion, there is normal abduction in this eye, and don't forget the other eye, and normal adduction on the other eye, on the left eye. On levoversions, the eye doesn't adduct, and there's also narrowing. Actually, the narrowing is not evident. Okay, it's not evident in this photo, but there is upshoot, and that's why I think Dr. Hasika said, or I said, I don't know. I will say it in a moment later on, that the hallmark of Duane is narrowing, but also sometimes it is so subtle. So we will get some exceptions, and we will go through the exceptions at the end of the presentation. But this is a features that, when combined, points to the diagnosis of Duane. All right.
Ma'am?
Yes.
If the same case comes, like we can describe all the features and we can say, I think it could be type 2 ones. But if at all they ask for differential diagnosis, what can we answer in such case, ma'am?
Okay. So if you are not confident with your diagnosis, you describe the signs. So it's always better to describe, like fundus photo. So I'm not sure what is the lesion in this fundus photo. You describe the findings. And hopefully by describing the signs or describing the findings, in the meantime, you will come up with a list of differential diagnoses. And luckily, if hopefully you will get one, the actual diagnosis within the list of differential diagnoses. So if I'm not confident or I'm not sure, I will describe the findings. This is a left fistula for sure, and this is it seems for me as an exotropia in the right eye. Okay, and on dextroversion, dextroversion is normal in both eyes. So here the abduction is normal and the adduction is normal, but the most striking features is on adduction. This eye doesn't adduct, and there is upshoot. So so the upshoot could be due to Duane syndrome. Don't say any type. So if you are not sure of the type, don't say any type. if you are confused about the features of each type, don't say any type, just describe it finally. So there is upshoot, it could be Duane, and it could be inferior oblique overaction. Okay. So this is the most common causes for differential diagnosis.
Okay, ma'am.
So let's say inferior oblique overaction, and you can add inferior oblique overaction could be due to, could be primary or secondary. Okay. What's the meaning of secondary inferior oblique overaction? Secondary inferior oblique overaction, it happens secondary to superior oblique palsy in the right eye. But you already know that superior oblique palsy doesn't cause this, mainly doesn't cause this fistern. Yes, it causes contralateral fistern, but mainly there is some head tilt. So they should present you with a head tilt photos. And you can say it could be primary inferior overaction, but for maybe it's a case of exotropia with primary inferior overaction with severe, like grade 4 in primary inferior oblique overaction.
Okay,
ma'am. But I don't know, but there is slight narrowing here, maybe not evident, but slight narrowing here. But again, if you rethink again, if you have a case, have you ever seen a case of exotropia with inferior oblique overaction? We usually don't have this fistern, right? So cases of esotropia or exotropia with inferior oblique overaction doesn't actually cause fistern. So fistern, one of the main features again of Duane syndrome. How about the last type? The last type is like a combination of both. So remember the first type, type 1. Focus on type 1, forget type 2, because it's rare and confusing, as we just went through the previous slide, because there is some inter-observers variations. Type 3 is a combination. So we have here limited abduction and limited adduction, and it could be ortho or ET or XT. And the fistern depends on the alignment in the primary position. And this is, by the way, this is called Hooper classifications. This is from Canis Wright. Dr. Hassiga, can you comment on this photo? Composite photo? Yes.
The child has right face turn, and in primary position there is slight exotropia in the left eye. On dextroversion there is some adduction limitation. There is some adduction limitation in the left eye. Levoversion is normal, ma'am. The dextro elevation, there is upshoot in the left eye. Dextro elevation, yeah, it's upshoot in the left eye.
Excellent, excellent. So according to your description,
yes, it is.
Yes.
Yeah.
So there is some agreements between you and the Canis Wright. So we have a right fistern, and it means that the dextroversion, the problem lies in the dextroversion. There is some issue with the dextroversion. Could be on the right eye, could be on the left eye. So once you see right fistern, focus on the dextroversion. So you said the adduction is limited because you see here the nasal limbus. So you see here the nasal limbus in the left eye. So this is not full adduction.
Yes, ma'am.
And somehow compare the left eye by the right eye, there is some narrowing. Somehow. But yeah, it's subtle. But this is Duane. And as you can see here, the upshoot was evident in a slightly dextro elevation. So sometimes the upshoot is not evident in straight, like exact dextroversion. Sometimes you need to put the target slightly up and notice the upshoot. So here the upshoot is evident on dextro elevation, and you mentioned this perfectly and correctly. So there is right fister, there is exotropia in the left eye, there is limited adduction with narrowing, there is upshoot in dextro elevation. The only difference that you said the abduction is normal, but if you compare this by this, you will see here this is actually slightly levodepression, maybe perhaps, but you see here the temporal sclera. So there is a rim of temporal sclera behind the temporal limbus. So there is limited abduction.
Okay, ma'am, I missed it, ma'am.
That's okay, because I see sometimes the photos are not clear, but you can, let's say, justify your answer. Since you said, so the examiner may say, do you consider, so if you missed the diagnosis or you said something wrong, the examiner will give you a hint. So he will say, for example, do you think the abduction in the left eye is normal? So you look again. Once he said this, you have to recheck your answer. Again, once again. So the examiner is very helpful. If you said something wrong or you missed something, you will give you a hint. Once he gave you a hint, you have to recheck your answer. So this is an exotropic, let's say exotropic Duane. If you want to say the type, you can say type 3 with upshoot.
Dr. Ghada, I had one doubt in the previous thing. So on levo version, if we are seeing, there is limitation of abduction in the left eye, and is there limitation of adduction in the right eye also?
Sometimes you can't judge on the photos, because if you see here, there is also narrowing. The right eye relatively narrow, it is narrow relative to the primary position. So some examiner may consider it as a bilateral case with asymmetric presentation, like marked asymmetry.
Okay, thank you.
So some examiner or another observer may say there is narrowing here and there is limited adduction. But as you can see here, the abduction is full, right, Dr. Eva?
Yes.
So the abduction, so let's say the abduction is normal and you find limitation in adduction and narrowing. So according to the type, this is type 2, right? But
yes.
Given the fact that type 2 is very rare and it's very hard to have a type 2 in one eye and type 3 in left eye. So it's like a weird coincidence. So
so when in bilateral cases, it will be the same type in both eyes. Like it will be both type 3 in right eye as well as left eye.
I don't know exactly, but I have to recheck the references because most of my cases are unilateral. I don't remember bilateral cases. But interestingly, the new Kanitsky said the majority of twins are bilateral. Again, the common is common. So commonly the Duane is unilateral. Commonly it should be type 1. So from exam point of view. This case, I consider it as a type 3. And again, you said it is bilateral, but according to the files and according my initial, it's like 3 years ago, it was written in her files that it is unilateral. So here in the right eye, you will notice the narrowing. So an adduction on the right eye, there is narrowing. This is number 1. There is, as you can see here, you can see the nasal limbus and you can see even the nasal sclera. So we have limited adduction. Okay. And on dextrosation, there is limited abduction. So we have limited abduction and limited adduction. So this is type 3. How about the alignment?
Can we comment? Yes, ma'am. The alignment is a slight exotropia in the right eye.
Yes, slight exotropia in the right eye.
Ma'am, can we say in levo elevation there is upshoot, ma'am?
So here is this is a levo elevation. The eye here elevates and the eye here elevates. So this is not an upshoot. This is almost symmetrical, but because of the narrowing, you may get a false impression there is upshoot. There is no upshoot.
Okay, ma'am.
But here we have severe narrowing of the fissure with limited adduction, limited abduction. So this is type 3 on the right eye. Again, some of you said it is bilateral based on this photo because they think that I can see here the nasal sclera and the nasal limbus. So somehow there is limited adduction. And again, the abduction looks fine for me. So it is a weird coincidence to have type 2 with one eye and type 3 in other eye. So generally, according to her file, this is a unilateral case. But again, if you think that there is a bilateral, you can say it, but justify your signs. So here I removed the unessential information. So here type 1, limited abduction, normal adduction, ortho or ET. Type 2 is the opposite to the type 1. Type 3 is a combination, limited abduction, limited adduction, could be ortho, XT, or ET. And again, if you're confused about the types, just mention the signs. Mention if it is isotropic Duane, exotropic Duane, orthotropic Duane in the primary position. Describe the limitation in the horizontal movement, whether in the adduction or the abduction. Don't forget the side, and comment on the upshoot or downshoot. Sometimes the upshoot or downshoot is not evident on dextro or levo. You have to put the target slightly up to test for upshoot and compare the finding in each eye relatively. And for checking for downshoot, you may need to put the target a little bit down. Coming now to some details, but it might help you to remember the features. So as Dr. Hasika said, there is explanation for each finding in each type. For example, this is a type 1 Duane. So as you can see here, I draw the third nucleus because the third nucleus in the midbrain, so it is a higher level in comparison to the sixth nerve nucleus in the pons. So in type 1, there is, as Dr. Hasika said, there is agenesis of the sixth nerve nucleus. So that's why I draw a red cross on the sixth nerve nucleus. So it's not functioning properly. So the sixth nerve, you have hypoplastic sixth nerve, and the lateral rectus doesn't receive supply from the sixth nerve. So due to agenesis of the sixth nerve nucleus, we get poor abduction. So if you remember type 1, we have poor abduction. So what is the reason behind poor abduction or absent abduction or limited abduction? Because there is agenesis of the sixth nerve nucleus. There is no supply to the lateral rectus from the sixth nerve. This is the first pathology. Second pathology, the third nerve or the oculomotor nerve, which comes from the third nucleus, already supplies the medial rectus, but it's split abnormally to supply the lateral rectus. So when there is a firing in the third nerve and contraction of the medial rectus during the adduction, at the same time, the lateral rectus will contract. So that's why we say there is co-contraction of the medial rectus and lateral rectus on adduction in Duane's. And that's why the globe retract and there is narrowing. And since the majority of third nerve nucleus goes to the medial rectus, the adduction is normal. So you can see here the yellow arrow is thick because the majority of third nerve goes or the branch goes to the medial rectus, the one of the inferior branches of the third nerve. But a small branch goes for the lateral rectus. Here I'm demonstrating that when the medial rectus contracts and lateral rectus contract, they retract the globe behind because during the muscle contractions, the insertions comes closer to the origin at the apex, and the globe retract. As you see, 2 arrows here, and the fissure narrows on adduction. So 2 pathologies: agenesis of sixth nerve nucleus and split or disinnervation from the third nerve to the lateral rectus. And again, this is the findings or the clinical features of type 1. No type 1 by heart. How about type 3? As you can see, I omitted the type 2 because it's rare. So if you remember type 3, we have limited abduction and limited adduction. What is the reason for this? Because here the third nerve splits equally to the medial rectus and lateral rectus. So this equal split will compromise the innervation to the medial rectus, so we will get limited adduction. Okay, but still we have limited abduction because the sixth nerve, the original supply for the lateral rectus, is not functioning. And this is the explanation for the findings of type 3. So in type 1, the split in the third nerve is not equal or unequal. The majority goes for the medial rectus, and that's why the adduction is normal. But in type 3, the split is equal, and this compromises the function of the medial rectus and make it the adduction limited. But still, the abduction is limited because there is no lateral sixth nerve supply. We went through this picture before, and this is like you might get in the undergraduate MCQ questions, or maybe in basic science, violation of Sherrington law. If you remember Sherrington law, whenever there is impulse to one muscle, like the medial rectus, it should be at the same time inhibitory impulses, reciprocal inhibitions to the antagonist. So, but here in Duane, the medial and lateral rectus are contracting at the same time. So this is an example of violation of the Sherrington laws. So the hallmark of Duane, once more, is narrowing on adduction, and it could be subtle. So you have to be careful, and limitation on version testing. As additional features, upshoot or downshoot. And there is something called alphabet pattern, like V pattern. So there is V pattern, and it is omitted in the new Kanetsky, by the way. It's not written in new Kanetsky, but you know, while testing the version, you test the version up gaze and down gaze, and notice if there is any pattern. But the most commonly pattern in Duane is V pattern. And don't forget, this is a case you should evaluate the case from basics. You have to check for refractive errors and for amblyopia. So this is like the standard cure. Sometimes the Duane case doesn't require surgery, but still they need glasses, for example. So you have to check for refractive error to do patch therapy or amblyopia treatment. So this is, you should mention this as well in the management of any case of Duane syndrome, as in any case of squint. Sometimes we have seen cases of Duane with accommodative esotropia. We have 2 pathologies. So we give them like plus spectacles. So don't forget to check, to go through the basics like psychoplegic refraction, fundus examination, anterior segment evaluation, pupil evaluation, everything, like in any case. And by the way, The most described refractive error in Duane is anisometropia. Here, there is a list for what are the causes of upshoot or downshoot on adduction. And one of the main causes is Duane. And sometimes one of the surgical interference in Duane syndrome is due to the upshoot or downshoot. Sometimes this is the main indication for surgery. Here in this diagram, I don't remember the reference. One of the theories behind why there is upshoot and downshoot in Duane is mechanical theory due to tight lateral rectus muscles. So the lateral rectus, due to its tightness, because it's very tight and it's contracted during the adduction, there is some slippage of the lateral rectus around the glue. So this may result in downshoot or upshoot. And there is a specific surgery for treatment of upshoot and downshoot. Since the most accepted theory is tight lateral rectus, sometimes recession of lateral rectus is enough. Sometimes they add something called Y splitting. So as in this diagram, there is Y splitting. You split the lateral rectus into two halves, upper and lower. This surgery is described for upshoot and downshoot, Y splitting of the lateral rectus. All right. So again, we have three types, but if you are confused and not sure, you can just describe the signs. Don't forget the most important to comment on the primary position. First, if there is abnormal hip posture or not, and then the alignment in the primary position, whether it is orthotropic, isotropic, and exotropic. Here, I wrote the points to be assessed in the basic points to be assessed if you have confronted with a case of Duane in the exam. Number one, is it unilateral or bilateral? If it is unilateral, you have to mention the side, right eye, left eye. If it is bilateral, you have to say if symmetrical or asymmetrical, and which side is the most more affected. Number two, is it isolated, or it looks like the patient has a syndrome like golden hair syndrome? And what is the alignment in the primary position? Is it ortho or ET or XT? Simply, you may start by Hirschberg, and according to the instructions given by the examiner, you may ask to do cover test. Number four, whether there is, so I missed this type. So we have to mention the type. Is it type 1, type 2, or type 3, or what is the limitation? So there is a missing point here. What is the limitation in adduction or abduction? Is there any upshoot or downshoot? Is there any abnormal hip posture? If there is V pattern or not? And you have to mention orally, you have to check for amblyopia and refractive errors. And you have to decide whether it needs a surgical interference or not. And this leads us to the importance of knowing some points about the indications for surgery. And it's written in Kaliski. I'm not going to talk about it. And you have to know that we do recession. So if it is isotropic, you recess the medial rectus. If it is exotropic, you do recess the lateral rectus. So resection is contraindicated. Any strengthening surgery like resection or plication is contraindicated. Generally, is contraindicated in Duane, because if you resect the one muscle, the narrowing and the co-contraction will become more evident. So the examiner perhaps wants to hear to this piece of information. Resection is contraindicated. We do recession. So suppose if you have an isotropic Duane and significant angle, don't say I'm going to recess the medial rectus and resect the lateral rectus. This is a failing answer. So we have to say recession of the medial rectus on the affected side, and if the angle is significant, you can add the recession of the medial rectus on the other side. So we'll do bilateral recession of the medial rectus. So always recession, okay? Never resection or plication. And for upshoot or downshoot, you may consider Y splitting of the lateral rectus. Another point, if you have an isotropic Duane and you resist the medial rectus, you are trying to improving the alignment in the primary position, and you are trying to improving the abnormal hip posture, but still the abduction still will be limited. So in type 1 isotropic Duane, whenever you do resist the medial rectus, still the abduction is limited. So again, don't forget the hallmark of Duane. And this is an example from this book. This is an example of when the hallmark is not evident. So Dr. Hasika, can you comment in this photo? We are focusing today on you because you are the only one who is going to the exam.
And I'm scared of
so the lecture is about you. It's all about you. It's only for you. It's a private lecture for you.
So
it seems to me you are sitting with someone else and you are asking.
Yes, ma'am. Dr. Ramya, ma'am. We both are.
Yes.
Actually, she's my sister-in-law, and we both are appearing for the exam, ma'am.
So you have an emergency situation in your family, like.
Yes, ma'am.
Okay. So here, this is an example when you have only 2 photos. And this is strange because if we are going to give you a printed image or printed photo for Duane, we should give you 3 photos, like primary, dextro, and levo. But here is this book presented us, give us 2 pictures. Yes, and interestingly, the hallmark is not there. So please answer. So the top photo is the primary position. So comment on the primary position. Don't forget an important sign. I want to listen to the most important sign. Don't forget it. So we will see. Say it. Start talking.
The first picture shows central Hirschberg's reflex, ma'am.
Yeah,
almost central. So it seems to be in orthotropy position.
So this is the primary position, and if you notice the comment, it is exactly orthotropia. Okay. So this is because this is a strabismic book. He said or she said orthotropia, but Kaniski is a general book. It's a general ophthalmic book. It's not a specialized book. So they wrote straight eyes, but better to say orthotropia. Okay. Okay. So this is let's say this is the first sign. We have another sign in the top photo. We are trying to extract all the information from you. Yeah.
The child is wearing glasses.
So this is really important. The child. Again, you said an important word here, the child. So try to be like elaborate. So this is a child, this is a girl, this is an infant, this is a toddler. This is a white complected child wearing glasses. So there might be an underlying refractive errors. Okay.
Refractive error. Yes.
And he is blue eyes, as you see. So he white complected, and it seems to me. How about the pupils?
They are well dilated, ma'am.
Yes, it looks as they are dilated. Although, you know, light colored iris have a larger pupil, but I think it's dilated. They are dilated. So this is the top photo. How about the bottom photo here?
Bottom photo.
Okay,
describes.
So without, so the examiner might not tell you what the gaze is, but you have to predict, because it seems to you this is the primary. So this gaze should be
extroversion.
Yes. So the extroversion. What's the problem here?
On extroversion, there is limitation of abduction, total limitation of abduction in the right eye.
Yes. So what is your provisional diagnosis?
Yeah, it could be type 1 Duane syndrome.
So
in the right eye.
how do you know type 1? Because we don't have a picture
Yeah, we
for...
don't have. Yes, ma'am. We don't have the other levo version. I
Yes.
can't comment.
Yes, because if the adduction is full, it will be type 1. If the adduction is limited, it could be type 3, right?
Yes,
But
ma'am.
again, if there is an abnormality in adduction, I think the author will present us with the photo. So we assumed that the adduction is normal, and we assumed that the fact that the type 1 is the most common. So this is probably type 1, okay?
Yes, ma'am.
And as you can see here, he doesn't comment on the type because some of strabismologists doesn't care about the type, actually.
Okay.
And as you can see here the hallmark, because there is no photo for levo version. You can't see the adduction, you can see the narrowing, but at least, Dr. Hasika, you can appreciate the widening. You see the upper eyelid is elevated above the at the limbus, the upper limbus, so you can appreciate the widening.
Okay,
right?
ma'am. Yeah.
So
Yes,
despite there is no adduction, compare the fissure on adduction on abduction in comparison to the prior position.
Yes.
So you can add here, there is widening of the fissure on attempt because the child is not abducting. So on attempt abduction, on attempt abduction, there is widening of the fissure. So this is for sure Duane syndrome in the right eye. All right.
Okay.
So let's recap the findings again. So in the top photo, we have a child with wearing glasses with central corneal reflection, central Hirschberg in both eyes. So it seems to be an orthotropic patient, and the pupils are pharmacologically dilated. In the bottom photo, this is dextroversion. There is limitation in the abduction in the right eye. It doesn't move beyond the midline. And also there is a widening of the palpebral fissure relative to the primary position. The left eye is normal. So my provisional diagnosis, this is a case of Duane syndrome in the right eye. On follow-up questions, and I may add that I need to check the levo version to see whether there is limitation in adduction, so or normal. So if the adduction is normal, this is type 1 Duane. And I will see also narrowing of the, I will check for narrowing of the fissure on adduction and see if there is upshoot or downshoot. And also I have to test for up gaze and down gaze to check for V pattern. And check for refractive error or amblyopia. The glasses may be changed according to the evaluation. And I have to decide whether it is isolated Duane or associated with other abnormalities like deafness. And that's it. And I may ask for family history because some cases are familiar. You can add this in oral discussion. Okay. So suppose you don't have the photo for narrowing of palpebral fissure on adduction, or the narrowing is, you are not sure about the narrowing. The second, there is a clue for diagnosing Duane syndrome. And as a strabismologist, we depend on this clue more than the narrowing, actually, because nowadays the cases are, we are seeing cases in early infancy. So the narrowing is so subtle, but we depend on a clue, a secret clue, which is the marked discrepancy between the angle of strabismus and the limitation or limitation of movement. So in the first photo here, this is orthotropia, right? But here there's no abduction. So if it was a sixth nerve palsy, it should be like severe esotropia in the primary position. So whenever you have a case and there is discrepancy, you have marked limitation in the movement, but in primary position there is orthotropia or slight angle, And that's why Kanitsky mentioned slight esotropia, slight exotropia. So there is marked discrepancy between the limitation of movement and the angle of strabismus in the prime position. This is mostly a Duane syndrome. So,
if it is the sixth nerve, there should definitely be an esotropia.
Yes, significant esotropia in comparison to the limitation of the movement.
Yes. Yes.
However, if you said for this case, there is a differential, it could be Duane, it could be sixth nerve palsy, the examiner will accept your answer because sixth nerve palsy is one of the causes of limited abduction. But he will give you a hint about the orthotropia in the prime position. So still he wants to the full answer, this is a Duane case. Still he wants the correct diagnosis. But it is not a bad mistake because it is in the differential. Because fistern occurs in Duane's and occurs in sixth nerve palsy in both cases. So you see, the correction of head posture is important when you are trying to comment on the alignment. Okay. So if you are going to comment on the alignment on the primary position, you have to correct the head posture. Okay. But you can check for versions while the with the abnormal head posture already there, because there is no change in the findings whether you correct the posture or not. But it's always good to if you remember, when you are testing the version, you start by primary position, if you remember, because primary position give you some clues. Try to get used of correcting the head posture. So it's like a first step. Comment on the primary position if you are holding the pen torch. So generally, the examiner will ask you to do versions, okay? Because there is no time to check for alignment. Because in my situation, I checked only for versions, and also Dr. Vellis' experience, he asked to check only versions in Brown's case. So I got a case of Duane syndrome and he got a case of Brown syndrome. And in both scenarios, the examiner asked for version. Okay. So first you correct the head posture and check. So you're already holding the pen torch probably to test for version. So have a clue about the primary position and proceed to testing the version by pen torch. So that's why some prefer to test the version by pen torch to take the advantage of Hirschberg test at the primary position. You can test the version by accommodating target, by pen, by anything. But the advantage of holding the pen torch is that you can like quickly check for the primary alignment by Hirschberg test. Although it's rough, but it's helpful. All right.
Ma'am, so you'll be holding the patient's head with one hand and you'll be holding the target in your other hand and you'll be doing the motility test. Is that how you're supposed to do it in the exam, ma'am?
Yes, in strabismus evaluation, you have to get used of using both hands, because if we go through the cover test, you are holding the cover, the occluder by one hand, and holding the target by your other hand. So you have to get used. And sometimes if the patient is adult, you will correct the head posture and instruct him to not move his head. At least,
okay,
at least when you are checking for the primary position alignment. But if we return to the abnormal head posture and you are doing the versions, it's okay, because the findings would be the same.
Okay, ma'am.
So suppose this child has a limitation in abduction, and we expect an ipsilateral fistern, like because you suppose this is a type 1, and but his suppose this patient has a slight esotropia, not orthotropia, like a small esotropia in the right eye, because this is type 1 esotropic Duane and we have limitations. So we expect a right fistern. Do you think if you are holding the target to the right side, does it change? Does the finding will change? Will that finding change if the child is adopting right face turn or not? It's still limited. Still limited. And by the way, if you cover the left eye to check for duction, and inversion testing, both eyes are open, but induction testing, you cover one eye. So if we cover the left eye and you are holding the target on the right side, still the eye can't move. So all the findings in Duane will not change on induction testing. If you cover the other eye, the limitation is still there. So generally, in strabismus evaluation, when there is a defective movement in inversion testing, you have to do duction. But there is no time to cover and check. So generally, the examiner will stop you at versions, and he asks you for version testing. But scientifically, whenever you have limited abduction, you have to cover here in this example, you have limited abduction. You have to cover the left eye and recheck again to make sure the limitation is still there. All right.
Ma'am, so in exam, like you said, usually they'll ask us to test for versions or ocular movements. So
Yes.
we'll start by fixing the head and start with the Hirschberg's and then do the ocular movements examination, right?
Yes.
It should include even the corneal reflex test, ma'am.
So Hirschberg is only at the primary position.
Primary position, yes, and then followed by the ocular movements test.
Yes.
Yes, ma'am. Okay.
So Dr. Ghada, so when first we will show Hirschberg's with the pen torch, then after that we have to shift to target and then ask the patient to follow.
Yes. Generally, in my exam, I was wearing a white coat and using the pockets of my white coat to put some tools. So in my pocket, I hold the pen torch. All right. So the advantage of pen torch. So I like to start by check the alignment in the primary position by pen torch by Hirschberg. Although the examiner asked me to do version, but it's generally when testing the version, you start by the primary position. So at this, you check for the alignment as a primary position, and Hirschberg will give you a clue. Then use the same pen torch as a fixating target to test the versions. But
ma'am,
yes, go ahead.
Ma'am, the same goes for cover uncover also, no, ma'am? Suppose if they ask you to perform a cover uncover test.
No, cover, you have to use an accommodative target.
Accommodative target, yes.
Okay, but if they ask you for cover test, they will be specific whether to do cover test at near or at distance. It depends. But I don't know. I already asked about cover test because I didn't see an inexperienced cover test. I don't know. But you have in my pocket, I kept my accommodation target as well, just in case they ask me to check for alignment at near. So at near, you should holding at the accommodative target, some fixation target with a printed image or a printed small fonts. Okay.
Ma'am, while performing cover uncover also, we'll be correcting the abnormal head posture, and then only we'll be performing, no, ma'am, in the primary position. After correcting it only, we'll do a cover test, no?
Yes, before cover test, you should correct. This is a very essential requisite. This is an essential step because in cover test, you are commenting on the alignment. This is the short test for accurate commenting on alignment. So you have to correct the abnormal head posture. So correcting the abnormal head posture is a good step before version testing, but not essential. But if you want to check the alignment, you have to correct the abnormal head posture, whether by Hirschberg or whether by cover test. You must correct the abnormal head posture at first. You're welcome. Okay, this is the last slide in today's talk. And this is a copy paste from my written experience. And it was, my final exam was in Amman, 2014. And let's read together. So my first case in in the neuro and ocular motility station, the examiner asked me to examine the ocular motility, and he said motility. He didn't say a professional term like versions. So they are trying to simplify things, but we as a candidates, we try to complicate things. And you will realize this later on after the exam. So he asked me to check for the motility. And he was a child, an older child with left side Duane syndrome. So as you can see here, I'm writing the side. So Duane syndrome, left side. And I did comment on the type, and I justified my answer because the case has limited adduction and abduction. And it was isotropic. So as you can see here, I commented on the alignment in the primary position. So I commented on the side, the first turn, the alignment in the primary position, and I justify my answer for the type. And I mentioned it looks to be isolated. And I mentioned the negative, the relative negative. You know, in commenting on a case, you may end your answer by mentioning the negative relevant points to show the examiner that you already know that there might be upshoot or downshoot in Duane. So I commented on the absence of these signs. So there is no upshoot or downshoot, and you can add there is no V pattern, for example. So you are showing the examiner that you already know the features that you might find in Duane syndrome. And this case like took me a few minutes, and as you see here, the examiner was convinced by my answer, and he asked me to shift immediately to the next case. So there wasn't much talk in this case. I checked the case, I mentioned this paragraph, and he asked me to move. With this, I ended this presentation. I hope you find something useful today.
Very useful, ma'am. Very useful. Ma'am, I have a doubt, ma'am.
Yes.
If we get a case of congenital esotropia and comitant esotropia, then if we are asked to test the cover uncover test, should we start with ocular movements, Hirschberg's, and then do the cover test, ma'am? Like, how should we go ahead with the concomitant squint case?
Ma'am, it's like if they ask for ocular motility, should we also include cover and uncover test in ocular motility, or we have to directly go measure the, do the versions and inductions in that particular patient?
Okay. So as you can see from my experience, they asked me to do motility. They asked me to do motility, and I did only motility. I didn't do any cover test in this case, and Dr. Velez didn't do any cover test because cover test takes time, and they know this, and they know this is difficult for non-strabismologists, so they avoid asking these questions already because they already know that strabismus is a tough chapter. They already know that cover is tough for non-strabismologists, and they already give you a syndrome. So they already give you a difficult case, should be, but you answer it. So they try to simplify the case by asking for doing just the motility. All right, and there is no time to do both. So I'm expecting either you ask you to do cover or to do versions. It's hard, very hard to do both at the same setting unless you are a strabismologist and you do it fast. But I think because this is one, each one takes time. But what is the order? Suppose they ask you to do cover and to do motility. Again, they will give you the order. Now, they may ask you to do cover test first, and let's say they will ask later on to do motility. They may give you the order. So suppose they didn't say anything. suppose they didn't say anything and they say this is a case of squint, examine it, for example. And what is the order? We do cover test first and then the motility.
Cover test first and motility. Okay, ma'am.
But again, some do the motility first, then the cover test. But before my exam, I attended a clinical course, and they mentioned that you have to do cover test first and then the motility. And in my practice, it varies from case to case. So if I'm expecting an incompetent strabismus, I do motility first, then cover. But if I feel that this is a case of competent squint, I do cover and then motility, based on my experience. But in short, the short answer, do cover test and then motility. And if you change the order, there is no harm. You're welcome. Thank you all for joining me.
Dr. Ghada,
Yes, go ahead.
I had one doubt. This is it's not with connection to DRS. I just want to know, like, suppose we get a third nerve palsy case. So how do we go if the examiner just says examine? So what do we do first? Like first lift up the lid and then check the Hirschbergs, then do the motility, and then finally the pupils, or?
Yeah.
So what else? You mentioned everything.
No, in that order only, or anything else?
So if there is a severe ptosis, like total ptosis, you have to elevate the eyelids. This is the first step. All right. And you do Hirschberg. Suppose this is a typical case, like classical case, like complete total third nerve. So you will find exotropia. And next, you will test the vergence. You will find limitation in all cases except the abduction. All right. You will not have a time, but you need to dim the room, the lights, turn off the lights, and check for the pupil reactivity. It is dilated fixed. If it is the pupil is affected, dilated fixed. So no response to the light, dilated fixed. And again, there must be, if the pupil is affected, there must be anisocoria. So they have a larger pupil on the affected side. And in the anisocoria will increase in photopic, because in photopic the pupil doesn't respond, constrict, because you have to dim the
Yes, ma'am. In this case, I was wondering, like, do we have to tell again for pupil examination? Can we just do a quick pupil, or do we have to do like all the steps? First, see inspection with light, and then off the light, and then again do a direct.
So you already okay.
Alternate.
This summarize again. So again, you elevate the in well illuminated room, you elevate the upper eyelid. You see the exotropia. You check the vergence. You document the limitation. You will notice the anisocoria and the direct fixed pupil. You will ask the examiner to turn off lights. So to check the right pupil reflex, you will find it direct fixed pupil, and that's it, I think. And you have to tell the examiner orally to have to search for the cause.
So they will ask us only one of it. So we'll either do the ocular movements and then say that I would like to check the pupil also.
Yes, pupil is the last, because this is mainly an ocular motility test, because the finding regarding the strabismus are more than the finding regarding the new, I believe. But suppose I think because the patient is already have an exotropia and ptosis, so there is a significant external findings. So we have to take the order, like from, sometimes we study by orders, starting from anterior to posterior. So when you are examining the case, you start by examining the external features, the eyelids, the adnexia, the lacrimal system, the orbit, the eyelids, then go through the conjunctiva, cornea, anterior chamber. So this is a systematic order for examination. So you expect to check for the pupil after finishing the external features. If you are asking about the order. All right.
Okay, ma'am. Thank you so much, ma'am.
Thank you so much, ma'am.
We will celebrate your success soon, inshallah.
Hopefully.